So, good morning, everyone. Today we have a special session of Jaipur surgical tutorial where we are going to talk about the surgical anatomy of the neck. It is important for all GI surgeons who want to deal with esophagus, especially because if you believe in the philosophy of a subtotal esophagectomy and cervical esophagoconduit anastomosis, then exposure of the esophagus is an important part of the procedure. So, to teach us the surgical anatomy of the neck with special reference to esophagus, I have requested my faculty colleague here in the Department of ENT, Dr. Priyanshi. She's going to talk to us about the surgical anatomy of the neck. I've requested her to give more emphasis on esophagus, but also tell us about the adjacent organs because we need to be aware of them, of their anatomy, so that we don't cause an inadvertent injury to any of these structures. Priyanshi, please.
Thank you, sir. Thank you, sir. Very good morning to everyone who's logged in. So, from an ENT perspective, the surgical anatomy of neck is a lot more than just esophagus. So, we're going to be dealing with a bird's eye view of what the neck anatomy is and then going and specifying it to the esophagus. So, anatomy is to physiology as geography is to history. It describes the theater of events. Very quickly, what are we going to do in these 60 minutes that we have ahead of us? We're going to talk about the developmental anatomy, surface anatomy, triangles, fascia, spaces, relevant structures, lymphatics, vascular and neural anatomy, esophagus, and why do everyone here needs to know this. Looks like a long list, but we can be fast about this. So, developmental anatomy. From a head and neck perspective, developmental anatomy is of great importance, and the head and neck develops from the branchial arches. Now, we have 6 branchial arches, and if you can count the colors, we only see 5. And that's because the 5th arch regresses. Now, why are these arches important? It's because each arch has its own nerve supply, has its own blood supply and in cartilage. And they all together will form an understanding of the head and neck further. So quickly, the first arch is the mandibular arch and the nerve is the mandibular branch of trigeminal. The cartilage is Meckel's cartilage and we remember it with MI3 as a mnemonic. The muscles are the muscles of mastication, are TVP, TT, tensor tympani, anterior belly of digastric and mylohyoid. The artery of the first arch is the maxillary artery. And now if I go back a little, I want to show you this. So the first arch and the second arch has an external cleft and an internal pouch. Now these ultimately invaginates to form certain structures. And the structures that an internal pouch from the first arch forms is the eustachian tube, the middle ear cleft, and the medial surface of tympanic membrane. And the external cleft forms the external auditory meatus and the lateral surface of tympanic membrane. The second is the hyoid arch, which is the nerve of facial. We have a Ricard's cartilage here, which forms the lesser cornu in the upper body of hyoid, the stapes, and the styloid. Now, we're going to be encountering a lot of hyoid in our further lecture because, believe me, even a small bone has a very crucial anatomical significance when it comes to neck. So, the muscles are the muscles of facial expression, posterior belly of digastric, platysma, and stapedius. The second aortic arch artery is the stapedial artery, which ultimately invaginates. The internal pouch has a tonsil, and then it merges with the first. The third is the glossopharyngeal, which has a greater cornu in the lower body of hyoid, stylopharynges and constrictors of pharynx. The third artery is the aorta itself, and inferior thyroid glands and the thymic duct. The fourth is the vagus with SLN, which has the thyroid lamina as a cartilage and cricothyroid as a muscle. The artery is the ductus arteriosus or the fourth aortic arch. The superior thyroid glands are formed by the fourth arch. The sixth is our recurrent, which has cricoid and arytenoid cartilages. The muscles are the intrinsic muscles of larynx and the inferior constrictor. The sixth arch is ductus and the internal pouch is the parafollicular C cells of thyroid. Here I would like to point out that the third arch is giving rise to the inferior parathyroid glands and the fourth is giving rise to superior. That's because these nomenclatures are ultimately based on their final location. And like we can see, these parathyroids, they develop along with thymus. So thymus is to ultimately go into the thorax. So it pulls these pair of glands into the thorax, and therefore the ultimate location becomes inferior. That is another reason why we have a variable location of parathyroid inferior glands as opposed to superior, which have a very constant location. Now quickly talk about the surface anatomy, because we are going to be dealing with the nerves and all of this in relation to the structures. The first is, let's define what is neck. So the boundaries of the neck are the mandible, which is the lower border, and then inferiorly there's clavicle and the manubrium sterni. On the inferior side, medial side, we have the mylohyoid and the skull base. So this essentially has become our neck. Now to define neck, I spoke the first border is the mandible. So the lower border of the mandible is the most prominent bone on the face. Then we have mastoid processes. Mastoid process is a part of temporal bone, but again, it has the inferior limit as opposed to the superior border of neck. Now, hyoid bone, like I said, hyoid bone is a very important bone in relation to the neck. It has a body, a lesser gonu, and a greater gonu. All the important spaces and the triangles will be talked about in relation to this little bone, which is a horseshoe-shaped bone. Then when we come to the laryngeal framework, we have a thyroid cartilage and a cricoid cartilage followed by tracheal rings. Thyroid cartilage, like we can see, is a shield-shaped cartilage which has a superior horn and an inferior horn. And then we have a cricoid cartilage. So cricoid cartilage is the first complete ring when it comes to the thyroid laryngeal framework. In between the thyroid and the cricoid, we have a cricothyroid membrane, and below we have Sorry. So we were talking about the cricothyroid membrane. Now, cricothyroid membrane is a very important anatomy in terms of neck, because this is where we get an emergency airway access. Mind it, emergency airway access is different from a tracheostomy. A tracheostomy is done here at the level of the second and the third tracheal rings. So the boundaries for tracheostomy are The boundaries for a tracheostomy is here. Now, tracheostomy is done as taking the marginus supraclavicular fossa and the cricoid cartilage. So, between the cricoid and the supraclavicular fossa, we make a vertical incision, and there we do a tracheostomy. But when we don't have time to do a tracheostomy, we make an emergency airway access, and it is through this region, which is the cricothyroid membrane. Now, next, we talk about the thyroid gland. It's in another class in itself, but briefly, for this surface anatomy, we know it is a butterfly-shaped gland which has an isthmus on the second and the third tracheal rings. Then we talk about the sternocleidomastoid, a very robust muscle, which is the bulk of the muscle. This muscle is responsible for hiding very important vascular structures like internal carotid artery and IJV. Then we have the lymph nodes of the jugular chain, which are also present behind this muscle. Now, the significance why I want to point out this muscle here is, how do you exactly palpate the cervical group of lymph nodes? So we have to essentially tilt our head towards the same side of the muscle such that the muscle relaxes, and bend a little to the ipsilateral side such that the lymph nodes become prominent. Rotating the neck and the head to the opposite side will make this muscle taut and will make the palpation of lymph nodes difficult. Now, coming to the next, we want to talk about the marginal mandibular branch here. Marginal mandibular nerve is a branch of facial nerve which goes like this, comes into the neck, goes to the angle of the mouth. Now, marginal mandibular nerve is important to be saved in all the neck surgeries. That's because the lowest limit of the nerve is the greater gonu of the hyoid. The nerve will never go beyond this level. So when we make an incision for a lymph node excision biopsy or a submandibular gland excision, we take that incision 2 centimeters below the lower border of the mandible such that the nerve can be preserved. Now, the last nerve I want to talk about here is the spinal accessory. We know it emerges from the jugular foramen, goes down, divides the lymph nodes of level 2 into 2A and 2B. Then it merges into the substance of the SCM, where it will supply the muscle, goes to the roof of the triangle and goes into the trapezius. Now, quickly about the triangles of the neck. Now, what are these triangles? We have two triangles, anterior and posterior. The anterior are further divided into 4 triangles and the posterior into 2 triangles. So, the first triangle we want to talk about is a submental triangle. As obvious with the name, a submental triangle. So, the boundaries are the mental, the anterior bellies of the digastric, and the hyoid. Again, the hyoid we are going to encounter everywhere. So this submental triangle has fat as its content and small veins in level 1A group of lymph nodes. The second triangle I want to talk about is a submandibular triangle. This triangle is spaced between the anterior and the posterior bellies of digastric and the lower border of the mandible. Therefore, it is also known as a digastric triangle. The floor of this triangle is the mylohyoid muscle. This contains the facial vasculature, the facial artery, the vein, marginal mandibular nerve, and submandibular salivary gland, and 1B group of lymph nodes. Now, the carotid triangle is this triangle. The carotid triangle we can see from the boundaries. It's the posterior belly of digastric, stylohyoid, omohyoid, and sternocleidomastoid. As the name is obvious, the contents of the carotid triangle will be the carotid sheath. So carotid sheath has common carotid bifurcating into external carotid and internal carotid, the vagus, internal jugular vein, and at the back cervical sympathetic trunk. The floor of the triangle is formed by the hyoglossus, thyrohyoid, medial constrictors, and inferior constrictors. The last is the muscular triangle. Again, with the evidence of the name, the muscular triangle will have muscles, and it is placed between the two bellies of the omohyoid superiorly and the sternocleidomastoid inferiorly. Now, this has the infrahyoid group of muscles, which is sternohyoid, sternothyroid, thyrohyoid. Now let's talk about the posterior triangle. The posterior triangle is divided into 2 with the posterior belly of omohyoid. Now this is the occipital triangle and this is the supraclavicular triangle. The supraclavicular triangle has cervical, a brachial plexus along with subclavian artery and vein, and the occipital triangle has transverse cervical artery, has cervical plexus branches, and a number of other structures. The point to note here in the occipital triangle is that spinal accessory nerve, by traversing its course from the SCM to the trapezius, has essentially gone through the roof of the occipital triangle. So all the neural structures that are present in the occipital triangle are always caudal to the spinal. It is never cranial to it. Therefore, we find a plane of dissection in the cranial part of the spinal and then dissect these lymph nodes by preserving the cervical plexus branches. Coming to the skin of the neck, we have relaxed skin tension lines which are horizontal on the face and they become perpendicular gradually when they move towards the neck. The importance of having these skin tension lines is that any incision in these lines will give a cosmetically acceptable scar. Now, when we talk about the vascular supply of the neck, the vessels which supply the face and the neck skin are different. So, all the arteries that we possibly know of the head and neck, they form a plexus, which is known as the subdermal plexus, which is formed in the muscle, which is platysma. Now, these plexus muscles will then give a branch, which will then traverse through the fascia to supply the skin. So that is why whenever we raise a flap in the neck region, we always do it subplatysmally to save this plexus from damage and necrosis of the skin further. Now, lymphatic drainage of the skin goes to the superficial group of lymph nodes in the closest proximity to that skin. One point to note here is the parotid group of lymph nodes. Now, parotid group of lymph nodes are a very common site for occult metastasis of skin cancers. Therefore, parotidectomy is always preferred in cases of excision of skin cancers of head and neck region. The venous drainage of face is very interesting because when we're going to talk about the IJV and subclavian, it will give us an overview of where it came from. So we start with a supratrochlear and a supraorbital vein, which forms the angular vein. And this angular vein then joins the deep facial vein to form the facial vein. Now, this facial vein is joined with the anterior division of the retromandibular vein, which forms the common facial vein. So, mind it, we've already seen three facials for now. We have seen a deep facial, we have seen a facial, and we have seen a common facial. The common facial vein is the vein which ultimately drains into the IJV. Then the posterior division of the retromandibular vein will then drain into the postauricular vein, and together they will form the external jugular vein. And this EJV will ultimately go into the subclavian vein. Now, it's very important to talk about the facial layers of the neck, and that is because the fascia of the neck compartmentalizes the structures in the neck, and that helps and aids in the surgical dissection of these compartments because multiple organs are present in very close proximity to each other. So, for example, if I talk about the parotid. Now, parotid has its own compartment, which is enclosed by this fascia. So, while doing a superficial parotidectomy, I need not be bothered that I might enter into the masticator space until or unless I'm following these facial planes. So, that is the surgical importance of having the cervical fascia in the neck. Now, these has essentially two layers. One is the superficial and the other is the deep. The deep layer of fascia again has three layers, and we're going to briefly look at it. So first, let's talk about the superficial fascia. What is this? It is a very thin layer of fascia, and the only purpose of this fascia is it encompasses and completely encloses the platysma muscle. That is it. So we talked about subdermal plexus of vessels, which was inside the platysma muscle. Those giving the arteries, they go to the skin by piercing this superficial fascia. So this fascia then below will join and confluent with the fascia of the deltoid and pectoralis major. Now talking about the deep fascia. Let's look at this colorful diagram. Look at the red line which you can see everywhere. That is the deep layer or the investing layer of deep cervical fascia. Now this is present everywhere. It starts from the occipital protuberance, superior nuchal line, goes all the way anteriorly up to the mandible superiorly, mastoid process, zygoma. Inferiorly, it goes to the level of sternum and clavicle. So it is like a cover to the neck. Now, this investing layer involves and engulfs every structure in the neck. Like we can see the sternocleidomastoid, the suprahyoid group of muscles. Below, if we see a next cross section, we can see infrahyoid group of muscles, trapezius, carotid sheath. Now let's look at the blue diagram that we can see here. This blue layer is the pretracheal layer. We know this is the trachea, this is the esophagus. So anterior to trachea would be a pretracheal layer. Now this pretracheal layer has two compartments, a visceral and a muscular. Visceral, as the name suggests, it's obvious, will have a thyroid, the parathyroids, a bit of esophagus, and the muscular compartment will have the infrahyoid group of muscles. Now, when we look at the vertebra, the yellow line is the prevertebral layer or the prevertebral fascia. This is the limit. This is the surgical limit of neck dissection. We don't go beyond the prevertebral fascia, which is engulfing the prevertebral group of muscles and the vertebra. When we talk about carotid sheath is the condensation of all these three layers. So it is relatively dense and more strong as compared to the fascias on the other side. Now let's look at the spaces. So when we had already defined the triangle, what was the need to see a space? So triangle, by virtue of it being a triangle, is a two-dimensional anatomy, and the space is the three-dimensional space and the contents inside that 2D triangle. So now that we already know what the triangles are, it's easier for us to understand the space. So this is the submental space, which is in the submental triangle, which has mylohyoid as its floor. Now this is the submandibular space. Submandibular space again is in the submandibular triangle. The floor of the submandibular space is in direct communication with the oral cavity. The only structure separating the two is a very thin mucosa of the floor of the mouth and mylohyoid. So whenever we get an infection of this space or level 1B group of lymph nodes, mainly odontogenic, This infection rapidly spreads into the oral cavity, which gives rise to edema of this, which gives rise to edema in the oral cavity, compromising the airway. That infection, when is very focally located in the submandibular space, is known as Ludwig's angina. So when we get a patient of Ludwig's angina, they are rapidly progressive and they can rapidly develop airway compromise. So start with a very high dose of antibiotics along with giving a release incision to remove the edema. There is very little amount of pus, but it is cellulitis that has to be taken care of. Then we have a peritonsillar space. So this is the tonsil in the oropharynx. This is the superior constrictor muscle. The space between the muscle and the tonsil is the peritonsillar space. And infection in this space again will lead to airway compromise because this space, when enlarges, will push the tonsil medially, causing the airway compromise. Now, parapharyngeal space is like a chauraha of all the spaces we have in the neck. This space communicates with every other space we have in the neck. So this is essentially a inverted pyramid with a skull base as the superior limit and a hyoid as its inferior limit. Now this water-like blue line that you can see in this diagram is the parapharyngeal space. Now we had to divide this parapharyngeal space into two compartments. This tiny structure that you see here is the styloid process in a cross section. Now, why was there a need to divide these spaces into a pre-styloid and a post-styloid compartment? That was because in a pre-styloid compartment, the content of this was essentially the deep lobe of parotid and fat and a couple of lymph nodes. But the contents of the post-styloid compartment involves the vessels and the vagus nerve, glossopharyngeal nerve, cervical sympathetic trunk. So when we have a patient with a unilateral swelling, which is well defined, non-tender on the lateral side of the neck, it becomes difficult to differentiate whether it is a parotid deep lobe tumor or whether it is a schwannoma or whether it is a neuroma or a carotid body tumor. So there lies the significance of doing a radiology. When we do a radiology, we see like this is the fatty plane, which is the lymphovascular fat plane, which is separating the pre-styloid and the post-styloid. Now, in an MRI, the displacement of this plane will tell us whether the tumor is arising from the pre-styloid or from the post-styloid compartment. Like if you see here, this is a pre-styloid, giving a picture that it is a deep lobe of parotid tumor, displacing it medially and downwards. This is the post-styloid, giving an idea that it could be a schwannoma, displacing it superiorly and medially. It is only then, once we have confirmed whether it is a post-styloid or a pre-styloid lesion, we can then go for a FNAC to confirm our diagnosis and excision. The last space we talk about is the retropharyngeal space. Now, retropharyngeal space is a very complicated anatomy which could have been made very simple. Now, retropharyngeal space, if I would like to explain, is the yellow line we know we've seen as the superficial fascia, which was enclosing the platysma. The investing layer is pretty much everywhere. We have seen that it was like a cover to the neck. Now, the prevertebral fascia is this dark orange line that you see. Now, let's come to the retropharynx. The green line is the buccopharyngeal fascia. Behind that is the prevertebral fascia, which is the dark orange. Now, there's something which is between the prevertebral and the buccopharyngeal, and that is the alar fascia. Now, alar fascia can be considered as a supplementary layer to the prevertebral fascia. Now, when we define the spaces between the buccopharyngeal fascia and the alar fascia is our retropharyngeal space. Now, retropharyngeal space is essentially not seen in an adult MRI or a CT scan because this obliterates. The lymph nodes of retropharyngeal space regresses in adulthood. But in cases of retropharyngeal lymph node metastasis, the space will become evident and obvious and will give us an indication that the head and neck malignancy has gone to the retropharyngeal group of lymph nodes. So this is one of the occult sites of lymph node metastasis, which is generally not addressed in cases of head and neck. Now, the space between the alar and the prevertebral fascia is the danger space. Now, why is it known as a danger space? Because it goes down and communicates all the way down till the level of T2. So, infections of the neck, let's say we had a peritonsillar abscess, which went to the parapharyngeal space and then went back to the retropharyngeal space. Now, this space can then go all the way to the mediastinum and thorax because of this danger space. Now, the space between the prevertebral fascia and the vertebra proper is the prevertebral space. Again, like the retropharyngeal space, the prevertebral space also is not appreciated in a normal CT or MRI. It is only in cases where there is an infection. And the most common being a pot spine. So pot spine is a tuberculosis of the spine. So when the spine starts undergoing caseatic necrosis, this pus starts collecting, and it forms a bigger swelling. And that is when it will push the entire facial layers outward, and that is when we can appreciate it on a CT or MRI. Again, we have a carotid space. So carotid sheath engulfing is a carotid space. We have a couple of other spaces. Like I said, the advantage of having these spaces and the facial layers is, for example, I have a patient who is having parotitis. Now I know that the parotid space is very compact, and the infection of the parotid will not spread into masticator space unless or until it is very advanced. So before that, the patient is going to have severe pain and will have a quicker presentation. So it helps the spread of infection to different compartments in early presentation. Now let's look at the relevant structures. First is we're going to look at the muscles. The first muscle we're going to look at is the platysma. Now, platysma, we have spoken a lot that we need to go, there's a subdermal plexus, we need to go below the platysma to raise any flap in the neck. Just let's quickly see what this muscle is. It is a very thin, very superficial, fan-shaped muscle. It originates through the fascias of the deltoid and the pectoralis major, and finally, the angle of the mouth and surrounding region. Now, the muscles of facial expression, by the name itself, defines that the origin could be anything, but the insertion is always on the skin of the face. That is why contraction of any muscles of facial expression will give us a certain expression on the face. Now, platysma is supplied by facial artery and cervical branch of facial nerve. Now, some fibers of this muscle decussates near the mandible, but the majority of them is not there in the midline. Again, giving us a very nice open area for midline dissection to access the lateral structures in the neck. This is the star of the neck, the sternocleidomastoid muscle. We know very prominent anatomical landmark, divides into anterior and posterior triangle. Let's see, it has two separate heads. The sternocleidomastoid has a sternal head and a clavicular head. So when we talk about these heads separately, they have a completely different function than when they work in tandem with each other. So the sternal head is more tendinous, very strong, goes and inserts into the superior nuchal line. Whereas the clavicular head is fan-shaped, it goes more straight and inserts into the mastoid tip. So when this head contracts, it tilts the head to the same side. But when this head contracts, it rotates the head to the opposite side. And when both of them contract together, it rotates and tilts the head to the opposite side, like we see in cases of torticollis. Now, when all the four heads on both sides contract, it helps us in lifting the head from the bed, what we do first thing in the morning. Now, since the muscle is robust, it has a robust blood supply, pretty much like the esophagus. It is divided into three segments. The superior is by the occipital artery, the middle is by the superior thyroid artery, and the inferior is by the suprascapular artery. The nerve we all know is supplied by the spinal accessory with proprioception from C to C3.
So can the two heads of sternomastoid contract separately?
When we do a particular action, if we turn the head one side, we are only contracting with the clavicular head. And when we tilt and rotate to the opposite, we are using both the heads. Now let's understand trapezius. So this is actually what a trapezius is. But to an ENT surgeon, just this is what a trapezius is. It tells us the limit of our neck dissection and access to neck. We never go beyond the trapezius and the prevertebral fascia. But since we are talking about trapezius, let's look at it. We can see it is a very big muscle, very robust, and has a lot of origins. So the superior fibers, they originate from the protuberance, superior nuchal line, and the spinous processes of the C7, all the 7 cervical vertebrae, when they insert into the clavicle. So when these muscles contract, they will cause forward movement of the scapula. Now, when these fibers, which are originating from the spinous processes of the T1 to T12 contract, they cause the lateral rotation and the medial rotation and depression of the scapula. So the trapezius, we know, when it is in passive motion, it relieves the load of the head to the spine and it causes postural stability. The active action of the trapezius is elevates, depresses, and rotates the scapula. We know it is supplied by the transverse cervical artery. The origins we've discussed, and the paralysis of this muscle causes winging of scapula and drooping of shoulders. Now, very quickly, let's look at the suprahyoid group of muscles. So, all muscles above the hyoid are suprahyoid, and all muscles below the hyoid are infrahyoid. Suprahyoid, like we can see, we have an anterior belly and a posterior belly. Posterior belly's best friend is stylohyoid. They always go in tandem, similar blood supply, similar nerve supply, similar origin, similar insertion, everything same. And then we have mylohyoid muscle, and then we have the geniohyoid. So genial tubercle is over the mandible, and the muscle from the genial tubercle to the upper surface of the hyoid is the geniohyoid. Suprahyoid muscles have varying nerve supply. Anterior belly is supplied by trigeminal, posterior by the facial, mylohyoid by the nerve to myloid, again trigeminal, and geniohyoid by the same. Now, infrahyoid group of muscles are very interesting. What they do is they act as antagonists to the suprahyoid group of muscles. So, suprahyoid was actually elevating the hyoid at the time of swallow. And infrahyoid group of muscles, they depress the hyoid and they understand and modify the larynx to create a resonance during voice production. Now, these group of muscles, like we can see, sternum to hyoid, sternohyoid, sternum to thyroid, sternothyroid, thyroid to hyoid, thyrohyoid, and the last is the omohyoid. Now, very important aspect of the neck is the cervical lymphatics. Now, when we look at the lymphatics, they are divided into two groups. There is the superficial system and then there's the deep system. The superficial lymphatics, they drain the skin, which we've seen, and then they perforate that investing layer and then they drain into the deep nodes. So the lymphatics of the neck go in a very systematic fashion, that is from superficial to deep and from the deep from cranial to caudal. So we never get a lymph node at level 2 and we always get a lymph node at level 2 and then we'll go at level 3. It will never be that we get a lymph node of 4 and not level 2. So if it is 4, the chances are the 2 is always involved. That is why the lymphatics go from superficial to deep and from cranial to caudal direction. The deep lymphatics, we have divided them into a number of zones. And these zones, we can see here. One thing I forgot to mention is the predictable pattern of these lymphatic spreads. So each area of the head and neck will have a particular drainage area. And from that, it will go and drain into the rest of the nodes. So let's say, for example, I'm talking about the oral cavity, lateral border of tongue. Lateral border of tongue will first go and drain into the level 1B group of lymph nodes, which will then go to 2, 3, and so on. If there is an oropharyngeal malignancy, it will first drain level 2, 3, 4, and so on. All of these lymphatics and their predictable pattern is only there when it is a neck which has not been addressed previously by a surgery, by a radiotherapy or chemotherapy. Now, why was there a need to divide these nodes into various basins? That was because this was done at a Sloan Kettering hospital some 25 years back. And this was done in order to provide a uniformity to the between the radiologist, a pathologist, and a surgeon. So a surgeon would essentially remove a level 2 lymph node, but the radiologist would call it another, and the pathologist would describe it as a separate. So in order to create a uniformity, there was nodal basin description. Now we've already seen level 1A is a submental, level 1B is the submandibular, level 2, 3, and 4 are the jugular chain of lymph nodes, which are parallel and in tandem with the IJV. 80% of the lymph nodes in the neck are parallel to the IJV. Now, level 2 further divided into 2 by the spinal accessory nerve. That also we have seen in the occipital triangle. So, the one which is caudal is 2A and the one Thank you. So the spinal accessory nerve, the one which is cranial is 2B and the one which is caudal is 2A. Again, so if the 2A is removed, we have to remove the 2B. Now, 2, 3, and 4, and then we have 5A and 5B. So 1A is the submental, 1B is the submandibular, 2 is from the skull base till the hyoid, and 3 is from the hyoid till the lower border of the cricoid, and from the cricoid till the clavicle is the level 4. Level 5 is the supraclavicular and the occipital group of lymph nodes. It's not going. Okay. Now, level 6 group of lymph nodes is the central compartment. Now, the central compartment is between the carotid on either side, a hyoid on the superiorly, and innominate arteries inferiorly. It is amazing how a hyoid has become a landmark to everything. Now, this central compartment is addressed in cases of, what does it contain actually? It contains a paratracheal group of lymph nodes, perithyroid, parathyroid, precricoid. All these group of lymph nodes are together known as the central compartment. So when we do a total thyroidectomy or a thyroid dissection in cases of malignancy, we address the central compartment. Even cervical, esophagus, subglottic region, apex of the piriform fossa, central compartment is addressed. The 7th is the superior mediastinal group of lymph nodes. Now let's look at the nerves. The favorite nerve of an ENT surgeon, as you all must be knowing, is the facial nerve. The facial nerve might not be of great significance to a gastroenterologist, but to briefly give you an overview, it emerges between the pons and the medulla. The facial nerve will have an intracranial course, then will have a tympanic course, a mastoid course, and then will emerge out through the stylomastoid foramen into the substance of the parotid. Now, through this parotid, it gives various branches, which are 5. So, there is temporal, buccal, zygomatic, upper buccal, lower buccal, marginal mandibular, and cervical. This marginal mandibular branch we've spoken in detail about because it is important to preserve this nerve during any neck surgery. Damage to this nerve will cause the angle of mouth deviation, which is very evident. Now, let's look at the glossopharyngeal nerve. The glossopharyngeal nerve is the 9th nerve. And if you remember, when we talked about the embryology, it is the nerve of the 3rd branchial arch. Now, glossopharyngeal is very commonly known as the nerve of economy. Why? Because the poor thing is just making the ends meet. It will supply one muscle, one secretomotor gland, which is the parotid, one muscle, which is the stylopharyngeal, will have one special sensory from the carotid body and the carotid sinus as baroreceptors and chemoreceptors, one visceral sensation from the posterior 1/3 of the tongue as taste, and one area of general sensation, which is the pharyngeal plexus to oropharynx. So everything one is supplied by the glossopharyngeal. I'm sure you have that in mind that the inferior constrictors are supplied by the glossopharyngeal nerve, but they don't get a direct innervation from the glossopharyngeal. The glossopharyngeal gives a branch to the pharyngeal plexus, which then supplies to the constrictors. Now, we've seen essentially the branches of glossopharyngeal are tympanic, lesser petrosal, and pharyngeal branches. Now, let's talk a little about the spinal nerve. Spinal is the 11th cranial nerve. It is the motor nerve. It has 2 heads, a spinal and a cranial. So, from the spine, upper 5 to 6 cervical segments will send their cranial roots, spinal roots all the way up into the skull base, which will then join the cranial root and together will descend through the jugular foramen from the anterior compartment and middle compartment of jugular foramen. And when it descends down, we've seen the rest of the course. It descends down, goes to the level 2 of lymph nodes, gets into the substance of the sternocleidomastoid, inserts into the sternocleidomastoid the junction of upper 1/3 and middle 2/3. Then it supplies the muscle, will come out of the muscle just 1 centimeter above the Erb's point, and then traverses the roof of the posterior triangle and then goes and supplies the trapezius. So vagus. Now, vagus is a very important nerve from every perspective. The vagus is the 10th cranial nerve and it is the nerve of the 4th branchial arch. The nerve vagus is coming from a Latin word vagi, which means roaming, because of its great wandering course all the way from the skull base down into the abdomen. That is why it is known as a vagi. Now, vagus again originates from the jugular foramen middle compartment, and just when it comes out, it forms a ganglion, which is a superior ganglion. And from these superior ganglions, they contain the cell bodies of meningeal and auricular branches. We will discuss the branches just about in a minute. Then it has an inferior ganglion, and the inferior ganglion has bodies of all the other branches. Now let's look at these branches. The first branch of the vagus, just after it comes out from the jugular foramen, is the meningeal branch. Meningeal branch is sensory, it provides sensation to the meninges. The second is the auricular branch, and these two are only related to the superior ganglion. Now, when we come to the inferior ganglion, the second branch we get is a pharyngeal branch. Now, pharyngeal branch will go and join the pharyngeal plexus. The pharyngeal plexus is formed by the ninth glossopharyngeal and 10th nerve. But this pharyngeal branch is not the branch of the vagus itself. The accessory spinal nerve is known as accessory because it gives an accessory nerve to the vagus. And it is this nerve of the spinal which is then coming out from the pharyngeal branch to supply the pharyngeal plexus, which is then going to supply the muscles. So the motor innervation through the vagus is essentially done by the spinal component, which is contributing to the vagus. The next branch that we see is we talk about the superior laryngeal nerve. Now, superior laryngeal nerve is again given up very high in the neck. Now, superior laryngeal nerve will descend anteriorly and inferiorly onto the cricothyroid, and this will then go into the thyroid membrane in parallel with the superior laryngeal artery. Now, once it enters, the superior will give an internal laryngeal branch. The external branch of superior laryngeal nerve, which is EBSLN, will further go down over the inferior constrictor and will then supply the only tensor of the vocal cord, which is the cricothyroid. So we can see cricoid and thyroid. So cricothyroid is the only tensor of the vocal cord, which is supplied by the EBSLN. So in cases of thyroid surgery, we are supposed to be preserving two nerves. One is EBSLN and one is RLN. We're going to talk about RLN. Now, EBSLN is the tensor of the vocal cord. Now, for example, we are tying the upper pole and we manage to tie this nerve. What happens? If until or unless the patient is a professional singer, will not appreciate much change in the voice because nobody speaks at a very high frequency in a normal conversation. So EBSLN will not do much damage, but obviously preserving is important. Now let's talk about the recurrent. Recurrent is given lower in the neck. Now, recurrent has a separate course and an asymmetric pattern on the right side and on the left side. Now, on the left, first let's talk about the left. Now, on the left, the recurrent is coming all the way down and it winds around the arch of aorta to go up and traverses the tracheoesophageal groove to supply the intrinsic muscles of the larynx. Now, why does it have a separate course? That's because during embryological development, the ductus arteriosus on the right side. Now, remember we talked about ductus arteriosus as the sixth branchial arch artery. It regresses on the right side. So the nerve will then wind around the subclavian artery and go up. But in cases on the left side, the DA will go all the way down and will form the arch of aorta. So the nerve will also come all the way down with the artery, winds around the arch of aorta and then ascends up. But in 1% of cases, we might not have a recurrent course, and that is known as a non-recurrent laryngeal nerve. That is, the vagus will give a straight branch to supply to the intrinsic muscles of the larynx. Now, what do these intrinsic muscles of the larynx do? They do everything related to phonation, swallowing, and breathing. All the muscles of the larynx which helps in opening and closing of the vocal cords is supplied by RLN, except we've seen here cricothyroid, which is supplied by the EBSLN. After this RLN, we have cardiac branches which supply the cardiac plexus as a parasympathetic innervation. Then, so during the thyroid surgery, one very important triangle that we consider in order to preserve the recurrent laryngeal nerve is our Bear's triangle, the blue dotted area that we can see. So when we open, ideally when we do a thyroid, we do a midline dissection, we go lateral, lift the thyroid from its bed and then see the lateral structure. The first structure that we can appreciate is the common carotid artery, giving along with it from the medial side, we see an inferior thyroid artery. So lateral, superiorly and inferior thyroid and a tracheoesophageal groove. This is the region where we are likely to find an RLN in 99% of the cases. So this is how we identify an RLN during a thyroid surgery. The second is the Jones triangle that we use in order to identify the EBSLN. The Jones triangle is basically the superior pole of the thyroid with superior thyroid branches, the midline, and the strap muscles. So this triangle will give us the EBSLN. The importance of having a Jones triangle is the floor itself is the muscle that is supplied by the nerve. Now, pharyngeal plexus, we've already spoken about. It supplies all the muscles of the pharynx, except stylopharyngeus, which receives an individual supply from the glossopharyngeal nerve. It is formed by the ninth and 10th, and sympathetic and cervical plexus branches. So, blood vessels. We know carotid is the main artery of the neck and head. Carotid is a branch of on the left side, it arises from the arch of aorta. On the right side, it's coming from the brachiocephalic trunk. Now, carotid ascends up in the carotid sheath, where it bifurcates into internal carotid and external carotid. How we identify an internal carotid from an external carotid is through its branches. An ICA will never give any branch in the neck, whereas an external will have 8 branches. So the first branch of the ECA is the superior thyroid, but there are a total of 8 branches, which is superior thyroid, ascending pharyngeal, lingual, facial, post-auricular, occipital, and 2 terminal, which is maxillary and posterior auricular. Now, internal jugular vein is the primary drainage of the venous system of the head and neck. We've already seen how is this IgA formed. Now, IJV is basically a continuation of sigmoid sinus, which is the cavernous sinus component of the dural venous sinuses component of the skull. Now, sigmoid sinus comes down as IJV, and this IJV has an 80% contribution from the common facial vein. Now, this IJV and it again gets its supply from the inferior petrosal sinus, from the common facial, from the pharyngeal venous plexus, superior and middle thyroid, and thoracic lymphatic duct. Now, the brachiocephalic on both sides will then enter into the brachiocephalic. The brachiocephalic will enter into the SVC, and SVC will go into the right atrium. Now, because of this, right atrium and IJV has only one single valve communication. And that is the reason we can appreciate pulsations in the IJV, because they are the pressures with a backward flow. Now, coming to esophagus. Quickly, let's define what is esophagus. We all know it is a 25 centimeter long fibromuscular tube which starts at the level of C6 and goes to the level of T11. It has a longitudinal and a circular muscle fibers. It pierces the right crux of diaphragm to continue together into the stomach. Then it has a deep cervical, mediastinal, intercostal, paratracheal, and superior inferior tracheobronchial group of lymph nodes. Now, talking about the histology, we know esophagus has 4 layers. The one is mucosa, which is the innermost. Mucosa is non-keratinized stratified squamous epithelium, lamina, and smooth muscle layers. The submucosa has glands and papillae. The muscularis externa has a striated muscle on the upper third, has a striated and smooth in the middle, and smooth at the lower third. The adventitia is the fibromuscular adventitia. Talking about the constriction, since we as ENT do a lot of rigid esophagoscopy, it is important for us to know the constrictions of the esophagus. The first is at the cricopharyngeal sphincter, which is roughly 15 centimeter from the incisor teeth. The second is at the arch of aorta, which is 25 centimeter from the incisor. The third is at the bronchus, which is 28 centimeter, and the diaphragm, which is 40 centimeter. The vasculature, like we've seen, it in cases of sternocleidomastoid, this also has a segmental. We've divided into cervical, thoracic, and abdominal part. The cervical is supplied by the inferior thyroid artery, which is a branch of thyrocervical trunk, which is a branch of subclavian. Now, thoracic is supplied by the thoracic aorta, and abdominal is supplied by the left gastric and the left phrenic artery. The venous drainage follows the same pattern as the arterial, with cervical inferior thyroid veins. Thoracic is the azygous and the hemiazygous, and abdominal by the left gastric and short gastric veins. The innervation is again divided in segmentally. The cervical will have a parasympathetic from recurrent laryngeal and a sympathetic from cervical sympathetic trunk. Thoracic will have from thoracic plexus parasympathetic as vagus, and sympathetic as sympathetic trunk. And abdominal will have a parasympathetic as esophageal plexus and sympathetic from T5 to T12. Now, what was the take-home message for surgical gastroenterologists from the anatomy of neck is one important understanding of cervical lymphatics, because we know like one very commonly taught is a Virchow group of nodes, which is at the left supraclavicular nodes. So these nodes can also come from the malignancies of the esophagus and stomach. Then the vascular and neural anatomy with vagus nerve, spinal accessory, internal carotid, IJV, these needs to be understood in order to reach the esophagus. And the last is the very brief anatomy of the esophagus. So like every other department, ENT and gastroenterology should also work in tandem, because there are certain diseases in which they can have, depending upon the predominant symptoms, will have presentation either to the ENT or a GE surgeon. Can be foreign body, esophageal perforation, reflux disease, motility disorders like achalasia, esophageal carcinoma, epistaxis, and so on. Therefore, it is important to have a bird's eye view of the entire picture rather than focusing on a single system. Thank you.
Thank you, Dr. Priyanshi. Any questions from any of the participants? Any comments? So before anybody asks, Priyanshi, I will ask, in some patients with corrosive esophageal stricture, where the stricture is very high, we have no part of the cervical esophagus which is normal and which we can use for anastomosis. So then we have to go to the pharynx for a pharyngo conduit, whatever we are going to use, stomach or colon. So what is the basic technique to expose that part of the hypopharynx, and what are the issues involved if we want to anastomose a conduit there? Anything different from esophagus?
Sir, to access the pharynx, we have to access the laryngeal anatomy first. So the laryngeal cartilages have to be moved laterally, and behind that, like I said, trachea, and in front of the trachea, we have a pretracheal fascia. So entering the pretracheal fascia, elevating the trachea, and then reaching the pharynx is how we also do it. In cases of total laryngectomy also, where we create an anastomosis between the pharynx, that first we remove the larynx and then access the pharynx.
And some of these patients where we do a very high anastomosis, because they will definitely have aspiration, we have to do a permanent tracheostomy. So we offer them either swallowing or speech. So if we have to do a permanent tracheostomy, how does it differ from a temporary tracheostomy which is going to be taken out?
Sir, in cases of temporary tracheostomy, the stoma is there, but you have a first tracheal ring and the third or fourth tracheal rings. In cases of a permanent stoma, you've completely lifted the trachea and have made a stoma exterior.
So does it become like an end stoma?
End stoma, sir.
So can the trachea be mobilized to that extent that we can bring it out as an end stoma?
Sir, it is always done. Cases of TL also, total laryngectomy also, that is what we do. We remove the larynx, slightly mobilize the trachea, get the stoma out, and create a permanent stoma at the suprasternal region. In cases of temporary tracheostomy, like we do in every case, after the indication for which the temporary tracheostomy was done, we decannulate the patient. So how we do is we put a tube, which is a Portex tube, and once we know that the patient is maintaining and is not indicated anymore, we create a fenestra in the tube, and then we block the tube. Now that is done because the patient's the reservoir and the dead space while we do a tracheostomy is significantly reduced. So we're increasing the work of breathing when we're asking the patient to again breathe through the nose. So first we have to acclimatize that patient for that increased airway resistance, and we gradually start closing the tube by creating a fenestra. So once we know that the patient is maintaining respiration and saturation with a completely occluded tube, we remove the tube and then we close. The tracheal rings, obviously there is narrowing, but it regrows. And then over that, we suture the muscle.
So if we do a temporary tracheostomy and once we remove the tube, that stoma will always close on its own?
Always, sir. So we don't remove the tracheal ring completely. What we do is we incise the ring, we create a flap. So the moment we remove the tube, we put the tracheal ring back on the stoma. So eventually it heals. There have been times when we see a narrowing, but it heals.
There is a question, tracheoesophageal fistula, how to diagnose and methods of repair. I think that's a separate topic in itself, but in brief, I can answer that if an infant or maybe even a newborn is having choking when the child is being fed and there is excessive salivation, that is how you start suspecting that it may be a tracheoesophageal fistula. And the initial step is passage of a tube, nasogastric tube, which gets kind of stopped at mid chest. And then obviously you will instill some contrast and see.
I think sir is trying to ask tracheal fistula post tracheostomy.
Oh,
So
okay.
long-standing tracheostomy can lead to TE fistula, which is very common in cases of cancer patients because they also receive radiotherapy. So post-radiotherapy, there is a very, very common chance of having a TE fistula. So the first thing is we ask the patient to lower the dose of the radiotherapy. Second, the first thing that we get to know that there is a chance that there is a fistula is when the food particle starts coming out through the tube. So patient eats and the food particle starts coming out through the tube, and then there is coughing and aspiration every time the patient is trying to swallow. So that is the first indication we'll get to know that there is a fistula. In such cases, first thing we again do is put a Ryle's tube, stop radiotherapy, find alternate methods of cancer therapy if there can be. And then eventually, if the fistula is less than 1 centimeter in diameter, by putting a Ryle's tube, it heals in a span of 6 weeks. And if the fistula is more than 1 centimeter diameter, then we put a TE scope and then we suture. So there's a stent which is available between these two. That stent is placed temporarily to prevent recurrent regurgitation of food into the trachea. Meanwhile, we suture the tracheal part of the mucosa either by grafting a costal cartilage over there or just if there is approximation primary closure.
May I comment, sir?
Yes, Rajan, please.
Yeah. One interesting incident about pharyngocolostomy. I'd done a pharyngocolostomy, and because she was poor, I had used silk to do the anastomosis. And she's developed choking after the pharyngocolostomy. So we all attributed it to choking of food because of the larynx and being so close to it. But what happened was actually when we cut those sutures through the oral route, she was taking perfectly normally. She could eat and drink just like a usual colonic anastomosis. So I have started using only Vicryl for anastomosis, and I keep the knots outwards rather than inwards. I'd like a comment about that from Priyanshi.
So what we do is corneal suturing. Corneal suturing are transmural which has no knot or the mucosa is spared. So when we do a pharyngeal closure post total laryngectomy also, we don't pierce the mucosa in order to create a passage or suture. It is done in submucosal plane essentially. So there should be no reason why there should be a foreign body or a regurgitation. We have to preserve the mucosa in cases of oral cavity or pharynx.
Yeah, that's what I felt as well. The important thing to realize in head and neck surgery is recurrent laryngeal nerve injury or neuropraxia results in aspiration quite frequently. So when you're operating on the cervical esophagus, it's very important to make sure that you're not injuring advertently the recurrent laryngeal nerve.
Correct, sir.
Okay, so once again, I would like to thank Dr. Priyanshi for this presentation, and we are beyond 10, so we will close the session. Thank you very much.
Thank you, sir.